So, hello everyone, welcome to our Zoom meeting. Today we will have 4 items in our agenda. Dr. Wissam and our team will be presenting. So, Dr. Wissam, when you have a minute, you can take it over from here. And thank you so much, everyone.
Thank you, Dr. Nader, and thank you, fellows, for the meeting today. Today I will be the moderator, and so as you mentioned, Dr. Nader, today we have 4 topics. The first one going to be presented by Dr. Abdalla, Mohamad, and Alla Hamid about prostate disease. So, guys, if you're ready, you can start, and I can share the screen if you'd like.
Okay. Hello, everyone. This is Alla Hamid, and thank you all for being here today. Today, we'll be presenting an important and high relevant topic, which is about the prostate disease and cancer. Dr. Wissam, can you share the screen, please?
Okay, 1 second, please. Oh, 1 second. Let me just open that.
I'm going to share the screen for 1 second. This is the agenda items.
Okay.
And then Dr. Wissam, you can go ahead.
Okay, Dr. Nader, 1 second. So this is share sound. Okay, so share. Let me just maximize that.
Okay, so our topic today is going to be about the prostate disease and cancer.
Oh, 1 second.
Next.
And please let me make it in a format. Okay, 1 second. So,
And our focus will be on establishing a diagnosis of benign prostatic hyperplasia and to know different type of management of this disease, like lifestyle modification, pharmacological therapy, and surgical treatment options, and to know what to tell and to counsel the healthy men about the PSA, the prostate-specific antigen screening for prostate cancer, and to know which patient with prostate cancer are candidates for watchful waiting, and lastly, to recognize and treat prostatitis. So I hope by the end of the session, we will be all able to treat our patients confidently in clinical practice, whether they have benign prostatic hyperplasia, prostate cancer, or prostatitis. Next.
okay.
So to start with, as we all know, benign prostatic hyperplasia is a non-malignant enlargement of the prostate gland, and it commonly seen with aging. So the incidence increase with increase the age, and it develops in over half of the men more than 65 years, and an overwhelming majority of men after age 85. And regarding prostate cancer, is the second leading cause of cancer deaths in men after lung cancer, but many patients have asymptomatic or low-grade tumors. And the prevalence of prostatitis, which is inflammation of the prostate gland, whether it's infectious or non-infectious, it's around 10%, and it's similar in the prevalence to other diseases like the ischemic heart disease and diabetes. Next. As we said, benign prostatic hyperplasia is a non-cancerous enlargement of the epithelial and fibromuscular components of the prostate gland. And we have 2 concepts here, the microscopic benign prostatic hyperplasia and macroscopic. We say microscopic when it's only visible under microscope, but it's not yet large enough to be felt by the doctor during exam. And macroscopic benign prostatic hyperplasia means that the prostate has enlarged enough to be felt during digital exam, like during examination, or to be seen by imaging techniques. So microscopic benign prostatic hyperplasia only present in 50% of the patients by age 60. And It happens in 90% of men by age 85, and half of the men with microscopic benign prostatic hyperplasia develop palpable macroscopic benign prostatic hyperplasia, and those with macroscopic, only half develop clinical significant disease, and this needs medical attention. So patient with prostate disease typically present with either irritative symptoms, obstructive, or combination of two. So the other name of irritative symptoms is the storage, and these symptoms are frequency, urgency, nocturia. The obstructive symptoms, which are hesitancy, intermittency, weak stream, and incomplete emptying. So we have the International Prostate Symptom Score, which is a quantitative index developed by the American Urological Association for assessing the symptom severity and monitoring the treatment response. And it's adopted by the WHO. It's like a patient-reported questionnaire that made up of 7 questions. It's about nocturia, the symptoms, nocturia, weak stream, urgency, intermittency, and incomplete emptying and straining, as we said. And each question of those is scored from 0 to 5. So the total score is 35. And if it's 0 to 7, this is considered as mild symptoms. 8 to 19 is considered as moderate, and 20 to 35 is considered as severe symptoms. And when assessing this symptom score, this will help us to manage our patient, especially the long-term patient management, but has not been found to correlate with prostate size, urine flow rate, or post-void residual volume. And this means that we can have like a man who has severe symptoms with a small prostate, or minimum symptoms with a large prostate. Okay? So to diagnose prostate disease in general, we have to do examination. The digital rectal exam may be unremarkable or reveal an enlarged, smooth, rubbery, symmetrical gland. And one of the routinely used tools is urine analysis. We use it to evaluate the UTIs, hematuria, and glucoseuria. And sometimes we need to make another additional subsequent test, like the post-void residual volume, the urine flow rates, and the pressure flow studies, especially when we are uncertain about the diagnosis. Next. And now let's talk about how to manage benign prostatic hyperplasia. So the management could be lifestyle modification, pharmacological management, or surgical management. Surgical management usually used as the last result, but what are the indications of surgical treatment for our patient? It could be because of patient preference, dissatisfaction with medication, refractory urinary retention, or because of other complications of the prostate disease, renal dysfunction, bladder stones, recurrent UTIs, or hematuria. First, we will start with lifestyle modification of PPH. So we should reduce the nighttime fluids to manage the nocturia, eliminate the bladder irritants like caffeine, alcohol, and nicotine because they work as a stimulant, like a diuretic agent. And we should avoid other medications like anticholinergic drugs that aggravate the symptoms. So all these external factors, they work as contributors, and if we address them from outside, this could help improve the symptoms of our patient without even need further medications or surgery. Next. Usually, benign prostatic hyperplasia is treated with alpha-adrenergic blockers, and we have prazosin, a selective alpha-1 blocker. We have long-acting selective alpha-1 blocker like terazosin and doxazosin, and the slow-releasing long-acting selective for alpha-1 like tamsulosin, sildenafil, and alfuzosin. So the mechanism of action of these medications is to relax the smooth muscles in hyperplastic prostate tissue, prostate capsule, and the bladder neck, which decreases the resistance to urinary flow. And they have some adverse effects like dizziness, mild asthenia, which means fatigue, headaches, postural hypertension, and we should make dose titration to control this symptom. And it also causes abnormal ejaculation and rhinitis. So we need also to be cautious when we use the alpha blockers, especially for patients who are going to eye surgeries like cataract, because they might be susceptible to have intraoperative floppy iris syndrome, which is a sudden intraoperative iris prolapse and pupil constriction. And it's a potential risk of all alpha blockers with the greatest frequency and severity of intraoperative floppy iris syndrome among those using tamsulosin, because alpha blocker will not only work on relaxing the bladder neck while we are treating the benign prostatic hyperplasia, but it also works to relax the smooth muscles in the iris. So we need to be cautious before prescribing this medication, especially for patients with eye diseases. Next. Another medication that we prescribe for PPH is 5-alpha reductase inhibitors like finasteride and dutasteride. And the mechanism of action is to reduce the tissue levels of dihydrotestosterone, which results in increase the size of the gland. And it's most effective in larger prostate gland, more than 40 gram. Improvement in symptoms and urine flow rates may not be evident for up to 6 months. And what about the anticholinergic drugs? So we can use anticholinergic drugs to treat the storage symptoms, which is the irritative symptoms, when they are dominant in our patient with no significant obstruction. And we can use the anticholinergic in addition with alpha blockers if the patient has both the obstructive, the voiding symptoms, and the irritative symptoms. Next. And the phosphodiesterase 5 inhibitors can be also used for benign prostatic hyperplasia. We have tadalafil as a phosphodiesterase inhibitor that's commonly used. And the mechanism of action is phosphodiesterase inhibitor activity in the bladder, neck, and prostate. Prostatic urethra and prostate musculature contributes to urinary symptoms. So phosphodiesterase inhibitor usually breaks down cyclic GMB, which causes relaxation. So when we give inhibitor, the cyclic GMB will increase. It will not be broken down, and the increased cyclic GMB will cause relaxation, and this help improve the symptoms. And it's effective for men with or without erectile dysfunction. Only drug that can be treat both benign prostatic hyperplasia and erectile dysfunction, and should be used with caution when using with alpha blockers, because this might cause an additive effects of hypertension. And the last solution for benign prostatic hyperplasia is surgical management. We have different type of surgeries: transurethral resection of the prostate, open prostatectomy for those who have large prostate gland, transurethral vaporization of the prostate, transurethral incision of the prostate, and stent placement. And we should remove the rationale behind that is the removal or expansion of the periurethral prostate tissue reduces obstruction to urinary flow, and the indications is recurrent urinary tract infections induced by benign prostatic hyperplasia, in cases of recurrent or persistent gross hematuria, in cases of bladder stones or renal insufficiency. So the management of one of the complications that might result if we didn't treat benign prostatic hyperplasia correctly is urinary retention. The management is by using the bladder decompression, which is usually the urethral catheter, because it's a urological emergency and we need to act very fast, and maybe result from the natural progression of benign prostatic hyperplasia, or it may be precipitated by surgical procedures, most commonly because of the transurethral resection of the prostate, because of the scarring that occurred in the urethral tract, or because of infections or medications.
Thank you, Dr. Alla. Hello, everyone. This is Abdalla. Good evening, good morning for all. I will talk about the prostate cancer. The epidemiology of prostate cancer, most common non-cutaneous cancer among men in the United States. It is second leading cause of cancer death among men in the United States. The incidence will increase with the age and rare in men less than 40. Incidence varies according to race. Black Americans have the highest risk in the world. Among Black American men, prostate cancer occurs at an earlier age, has higher mortality rate, and tends to be at the more advanced stage of disease at diagnosis. Family history is also a contributing factor. Men with one first-degree relative affected have more than a twofold increase of the risk. History of sexual transmitted infection can be associated with increase of the risk. As we see, men with 50 to 59 years old have 23%, and men older than 80 have 80% in the autopsy studies. Most patients, especially those with early stage potentially curable disease, are asymptomatic. Direct invasion of the urethra and bladder can lead to irritative voiding symptoms, urinary incontinence, and hematuria. Extension of disease to adjacent nerves may cause impotence and pelvic pain. Also, symptoms of prostate cancer may be due to nodal metastasis and may cause extrinsic urethral obstruction. Lymphatic obstruction may result in leg edema. Hematogenous myths to bone may be cause severe local pain and normochromic normocytic anemia and pathological fracture and spinal cord compression. Less commonly, hematogenous myths may be involve the lung and liver and adrenal gland. Prostate cancer screening. It is controversially and the benefit of early detection and the best approach to treatment of the prostate cancer are controversial, as I will say. Most men with prostate cancer die with the disease, not from it. Guidelines agree that the controversy about screening should be discussed with the patient using a shared decision-making approach. Digital rectal exam that will allow palpation for posterior surface of the lateral lobes where cancer most often begin, can often detect local extension of prostate cancer into seminal vesicles. Part of the prostate glands cannot be reached. About half of the cancer, though to be confined to the prostate on the basis of digital rectal examination, are found during surgery have spread. Biopsy confirmed cancer in only about a third of the positive digital rectal examination. About the serum, prostate-specific antigen test, it is non-specific for prostate cancer. The elevation of prostate-specific antigen occur in benign condition of the prostate. The false negative rate, it will be from 30 to 40%. Positive predictive value about 30%. The normal measurements may improve accuracy. Prostate-specific density, prostate-specific antigen rate for change or velocity, age adjacent prostate-specific antigen reference ranges, ratio of free to complex prostate-specific antigen. The biopsy for diagnosing prostate cancer, abnormal digital rectal examination, or prostate-specific antigen test suggests the need for transrectal ultrasound guided biopsy. Spring-loaded core needle biopsies were routinely taken from the base and middle and the apex of each loop, 6 samples as total. Extended biopsy schemes from 10 to 12 cores with more apical and lateral sampling increase cancer detection rates. Biopsies may be taken from suspicious areas imaging by ultrasound MRI in addition to palpable nodules. Gleason grading system for prostate cancer. Gleason grade range from 1 to 5. 1 that's mean well differentiated and 5 poor differentiated. Gleason score that means summation of most common Gleason grading seen plus the next most common Gleason grade seen, range from 2 to 10. An example score are sometimes groups as 2 to 4, 5 to 7, 8 to 10. 2 to 4 well differentiated and favorable prognosis, but 5 to 7 moderately differentiated and 8 to 10 it is unfavorable prognosis because it is poorly differentiated. WHA grading system for prostate cancer, grade 1 and 2 and 3 and 4 and 5. Grade 1, Gleason score 6 or less, Gleason score less or 6, and grade 2, Gleason score 3 plus 4. 3 as we said, the first one, and 4 the most common worstly next one. It is equal 7. Grade group 3, Gleason score 4 plus 3 equal 7. Grade 4, Gleason score 8. Grade 5, Gleason score 9 and 10. Staging for prostate cancer, TNM stage, T1, T2, T3, T4, N and M, nodes and myths. T1, tumor is incidental finding. T1C, tumor is identified by needle biopsy as follow-up to screening that detected increased prostate-specific antigen. T2, tumor is palpable, confined to prostate. T3, tumor extended beyond the prostate capsule may involve seminal physicals. T4, tumor invade a decent structure like bladder and neck and rectum and pelvic wall. Lymph node N, lymph node is present. M is distant metastasis present. Staging for evaluation for prostate cancer. Initial evaluation will include prostate-specific antigen level, digital rectal examination finding, transrectal ultrasound result and Gleason score, bone scan on patient with bone pain or prostate-specific antigen values more than 10 nanogram per milliliter, multi-parametric MRI for patient electing active treatment, surgical assessment for lymph node involvement and prostate surgery or implantation for radioactive seeds. Sometimes we need the CT. Localized prostate cancer risk, stratification and treatment recommendation. We have criteria to define it as very low risk and low risk and high risk. If prostate-specific antigen less than 10 and grade group 1 and clinical stage from T1 to T2 and less than 40 biopsy cores, positive and no core with more than 50% involved and prostate-specific density less than 0.015, that will categorize as very low risk and will do active surveillance. Low risk, if it is prostate-specific antigen less than 10 nanogram per milliliter, and grade group 1 and clinical stage from T1 to T2. Active surveillance and definite treatment for selected patient. Group 3 intermediate risk. If prostate-specific antigen from 10 to less than 20, and grade group 2 to 3 or clinical stage from T to B, C, favorable grade group 1 or grade group 2, unfavorable if grade group 2 with either prostate-specific antigen from 10 to less than 20 or clinical stage T, 2B to C or grade group 3. The management for intermediate risk group, radical prostatectomy or radiation therapy, favorable, active surveillance possible, and comes with high risk for metastasis. The last group, high risk, prostate-specific gene, it is equal or more than 20 nanogram or grade from group 4 to group 5, radical prostatectomy and radiation therapy. Management for localized prostate cancer, we have watchful waiting and active surveillance. Watchful waiting for we defines as prostate cancer is not treated until symptoms develop. Offered to man with less than 20 years life expectancy and significant medical comorbidities, small, well-differentiated tumors, or unwilling to bear treatment burdens, awaiting for symptoms, sacrifices opportunity for cure. Active surveillance, that means prostate cancer treatment is delayed until evidence of disease progression. Offered to man with cancer detected by prostate-specific antigen screening, Gleason score less than 7, small volume involvement. Last one, radical prostatectomy. That means surgical removal for entire prostate and gland and seminal vesicle. Offered to man with absence of surgical contraindications. At first effects relies immediately. External beam radiation therapy, that means standard regimen deliveries from 6,000 to 7,000 rate of pelvic radiation over 5 to 8 weeks period. Radiation reach tissue outside the prostate, including pelvic lymph nodes. At first effect will occur initially from radiation-induced inflammation, then develop over time as the scar tissue develops. Brachytherapy, radioactive seeds are implanted into prostate gland using computed tomography CT scan guidance. Improvement in prostate imaging allow uniform disturbance of the seeds, overcoming past limitations. At first occur initially from radiation-induced inflammation, then develop over time as scar tissue develops. Okay. Management of locally advanced prostate cancer, radiation therapy is recommended. Non-adjuvant androgen deprivation, increased chance of survival and freedom from metastasis. Timing of androgen deprivation, it is controversial. Patient may have prolonged asymptomatic period. Long-term androgen deprivation can have substantial negative effect on quality of life, including loss of stamina, increased fatigue, hot flashes, diminished muscle mass, and premature osteoporosis. Patient should be given the choice of early versus delayed androgen deprivation. Androgen ablation for advanced prostate cancer, orchidectomy and luteinizing hormone, releasing hormone agonists are equally effective, reducing androgen to castration levels. LH releasing hormone agonists like leuprolide and goserelin produce castration level about months after initial increase in serum testosterone levels. Anti-androgen like flutamide are often given before luteinizing hormone releasing hormone agonists to blunt the effect of the testosterone increase. Complete androgen ablation slightly improve survival. Chemotherapy for advanced prostate cancer in men with metastatic hormone-sensitive cancer. The docetaxel delayed disease progression and enhances overall survival. Radiation therapy, useful for relieving the pain, isolated bone metastasis and reducing the risk of the fracture. Diffuse bone metastasis require alternative approach. Bone seeking, radiopharmaceuticals such as strontium or radium can be beneficial for the pain control. Androgen deprivation and biphosphonate can decrease the bone pain. The second topic about the prostatitis may have acute bacterial or chronic bacterial or non-bacterial cause. The source of the infection most commonly ascending urethral infection or reflex of infected urine into prostatic ducts. Direct extension or lymphatic spread from the rectum, hematogenous spread. More than 80% of the patients with prostatitis have no identifiable infection agent. The symptoms include fever, chills, dysuria, and buggy, tense, extremely tender prostate. Bacteremia may result from the manipulation of the inflamed gland. Minimal rectal examination is indicated. Gram stain culture of the urine can identify the causative agent. For diagnosis of the chronic prostatitis, marked by varying degrees of perineal pain and obstructive or irritative voiding symptoms. The prostate often feels normal. Compare first void and midstream urine with expressed prostatic secretion or urine collected post-massage. Expressed sample should reveal leukocytosis and the causative agent. Sterile expressant with leukocytosis suggests non-bacterial prostatitis. Treatment for acute bacterial prostatitis, antibiotic, and also may need hospitalization. Severe inflammation allow the antibiotic to penetrate the prostate. Initially, antibiotic selection is based on the urine gram stain result and subsequent consideration of the sensitivity. Fluoroquinolone are highly effective in most cases. Prompt response to empiric therapy is expected. If recovery is delayed, consider CT or MRI to evaluate for the abscess. Treatment for chronic bacterial prostatitis, antibiotics are less effective because of the poor penetration of the prostate by the most of these drugs. 6 to 16 weeks of therapy offers a cure rate for 30% to 40%. Continuous low dose of antibiotic suppression therapy can be offered to patients with frequent symptomatic relapse. Total prostatectomy offers cure but has high risk to benefit ratio. Transurethral resection of prostate is safer but cures only 1/3 of the patient. Treatment for non-bacterial prostatitis, we treat the symptoms. A small percentage of the cases involve occult infections. Empiric antibiotic therapy is often used. For reducing the pain and discomfort, we used anti-inflammatory agent, SIDS baths, fluid adjustment, and avoidal caffeine, anticholinergic agent, and alpha adrenergic antagonist. Choosing wisely, recommendation based on the American Board of Internal Medicine Foundation campaign, don't perform BT and CT scan and radionuclide bone scan in the staging of early prostate cancer at low risk of METs. A routine bone scan is unnecessary in men with low risk prostate cancer. Don't order creatinine or upper tract imaging for patients with benign prostatic hyperplasia. Don't treat increased prostate-specific antigen with antibiotic for patients not experiencing other symptoms. Thank you.
Okay, so to summarize, the treatment options of PPH include watchful waiting, drug therapies, minimal invasive procedures, and more extensive surgery. The choice of PPH treatment is influenced by the extent of the symptoms, the presence of complications from outflow obstruction, and the patient preference. The use of 5-alpha reductase inhibitors for PPH is especially indicated when the prostate gland is large. Patients should be informed that recommendations regarding screening for prostate cancer using the PSA differ among experts. The decision to screen a patient for prostate cancer should be made using a shared decision-making approach. Treatment options for localized prostate cancer include watchful waiting, active surveillance, and resection of the gland and seminal vesicles, and radiation therapy. How the patient balances the potential benefits and burdens of the various options will influence the choice of therapy. For patients with chronic prostatitis, efforts should be made to identify the causative organism. Even with a prolonged course of appropriate antibiotic, cure of chronic prostatitis can be expected in fewer than half of the patients. So we have some questions here we need to solve before ending. So the first question is, a 65-year-old man comes to the office because he has a frequent and urgent need to urinate. His symptoms have slowly worsened over the past year. No history of gross hematuria, acute urinary retention, or UTI. No family history of prostate cancer. The International Prostate Symptom Score, the total symptom score is 6 with a Boder score of 1. Examination, the phallus is circumcised, the bladder is not palpable, and there is no suprapubic tenderness. Rectal findings indicate a slight enlarged prostate gland without nodules or tenderness. The lab findings, the PSA level is 1.3, urinalysis, no microscopic blood, leukocyte esterase, or nitrate. So which of the following is the best next step in management? Lifestyle modification, cystoscopy, start tamsulosin, or start finasteride? So what do you think the answer?
A.
Yeah, correct. Because the patient has mild symptoms, so we only need to manage this patient by modifying his lifestyle. Okay, next. The second one is a 70-year-old man comes to the office because he has a frequent and urgent need to urinate. He reports no other problems, no history of urinary retention or UTI. He drinks 1 cup of coffee in the morning and diet soda throughout the day. His bowel movements are irregular and has not noticed any blood in his stools. International Prostate Symptom Score, mild voiding symptoms with low impact on quality of life. He has hypertension, atherosclerotic heart disease, and mild benign prostatic hyperplasia and osteoarthritis. Medications, tamsulosin, aspirin, metoprolol, hydrochlorothiazide, occasional acetaminophen for joint pain. On review of the systems, he notes that his vision has worsened, especially in the right eye. His ophthalmologist has recommended cataract surgery. And examination showed that there is a cataract in the right eye. Cardiopulmonary findings are normal. The abdomen is soft. The phallus is circumcised. Testicles are bilaterally descended with no masses, and prostate is normal size on rectal exam. Lab shows PSA is 1, urinalysis, no red blood cells, leukocytes, trace, or nitrites. In addition to the aspirin, which one of the following medications require adjustment before the cataract surgery?
A.
Correct. Tamsulosin. And then the last question is, 67-year-old man comes to the office to discuss management options related to prostate cancer. He has PSA of 5.2 and underwent transrectal ultrasound guided biopsy. The Gleason score was 3.3 equals 6 in 2 of 12 cores involving 30% of each core. He wishes to undergo watchful waiting and active surveillance. On digital exam, the prostate is enlarged, smooth, and anodular. So which one of the following is the best next step for this patient? Repeat PSA and biopsy to confirm pathology finding. Repeat PSA in 6 months and biopsy in 1 year. Order abdominal and pelvic computed tomography and bone scan to state the disease. Explain that he is not a candidate for active surveillance.
Do you mind to go back to the question, please, for a minute? Thank you. Okay. Question, please.
Eh?
Oh, no. Well, the answer is B. We need to repeat the PSA in 6 months and biopsy in 1 year because this patient has Gleason score of 3.3, which equals 6, and he is a candidate of active surveillance because he is at low risk of having cancer. So we need to follow the standard to repeat the PSA in 6 months, and then we have to confirm that by biopsy in 1 year. Okay? So this brings us to the end of the presentation, and thank you all for your attention.
Thank you, Dr. Alla and Dr. Abdalla, for this very informative prostate disease presentation. If anyone have any question, or Dr. Nader, if you have any comments.
Thank you so much. This great presentation, and thank you so much.
Okay, so the next topic for today is about schizophrenia in elderly, and it's going to be presented by Dr. Shiraz Eid. Shiraz, if you're ready.
Yes. Hello. Assalamu alaikum wa rahmatullah. I'm Dr. Shiraz حسب الرسول الطاهر. I will present today the schizophrenia and other psychotic disorder. Is my voice is clear?
Yes, it's clear, Shiraz.
Can you share the screen, please?
Okay, let me just open the... One second. Yes, 1 second, please. Oh. That's okay.
Yes. I will present today the schizophrenia and other psychotic disorder. We will start with the psychotic symptom. When we found patient he have a hallucination, that means he have perception without any physical stimulus. That means the perception of the thing without any stimulus, and that perception can be auditory, visual, tactile, olfactory, or gustatory. And the delusion, it is a false belief. The patient always he have fixed false belief, and this belief it can be suspicious, can be grandiose, somatic, self-blame, or hopeless. Next. Can you go back, please? Next slide. Yes. How the second slide? Number 3.
Number 3. Sorry
Yes.
for that.
Okay. Next. Yes. How to evaluate a person with psychotic symptom? First, we need to evaluate the underlying cause. If this psychotic symptom, it is due to underlying cause, especially in the elderly patient. If the patient he have psychotic symptom in the late age, like above 40, we should determine there is underlying cause like dementia, stroke, Parkinson, or substance abuse. And if there are the symptoms, this symptom, psychotic symptom, it is acute onset, or there is acute onset alteration in the level of the consciousness, we should suggest the delirium because it came in the acute phase. And the delirium also, it can be on the top of the dementia, and it is most common cause of the new onset psychosis in the late life. Only after other causes should excluded. If patient came in the late in older patient and he have psychotic symptom and we exclude the other causes, we can then diagnose the schizophrenia spectrum disorder can be met. Schizophrenia, it is a chronic psychiatric disorder, and it is characterized by positive and negative symptoms, and usually it is begin in the late of teen and 20s. If the patient came with schizophrenia in the late teen or 20s, we say it is early onset schizophrenia. If the patient came with this symptom or with schizophrenia in age above 40, we called it is late onset schizophrenia. What about the positive and negative symptom? The positive symptoms, this symptom present in the schizophrenic patient, but not in the normal patient, like hallucination, delusion, disorganized speech. While the negative symptom, it is that symptom present in the schizophrenic, not present in the schizophrenic patient and present in the normal patient. An example of that negative symptom like social withdrawal and apathy. And also, before we diagnose schizophrenia, we should exclude also the mood disorder and cognitive disorder. What the schizophrenia like syndrome of the late life, as we said before, if the patient came with this psychotic disorder in the age above 40, it is schizophrenia of the late onset, or it is of the late life, and it affects the female more than the male in the ratio of 5 to 1 or 10 to 1. And the patient most probably, or the prominent symptom, it will be the delusion and the hallucination. And the difference from the early onset schizophrenia, that the patient with late onset schizophrenia, he have lower incidence of the thought disorder. At the same time, he is have good personality, or the personality is preserved, and the social also is preserved. In the late onset, unlike the individual of the early onset schizophrenia, the patient can hold their responsibility of the job and can also marry and can have long-term relationship. But the most premorbid symptom for the late onset, it is isolation, especially the social isolated personality. What is the treatment for those patients with late onset schizophrenia? We have pharmacological and non-pharmacological treatment. The non-pharmacological treatment, we encourage the patient for maintaining important relationship, and also the therapeutic relationship, and ask them to discuss the source of the symptom with a close family member or friend. About the pharmacological treatment, the antipsychotic drug, it is used effectively in the late onset schizophrenia as well as early onset schizophrenia. And we adjust the dose, and we can increase the dose weekly or semi-weekly as needed. If the dose is adjusted and the patient have a response, we can continue the treatment for the 6 months. And if the patient he have relapse or the dose is lowered or not adjusted, we can maintain the treatment for at least 1 to 2 years. And also during the treatment, we need to monitor the extrapyramidal symptom like the Parkinsonian tremor and the dystonia and the rigidity. At the same time, we need to avoid the polypharmacological or to add different type of the drug at the same time. And also we should consider the anticholinergic medication. The pharmacological treatment in the late onset, it is the same drug that can be used in the early onset schizophrenia, like aripiprazole, acinapine, clozapine, olanzapine. Most of this drug, it is the dopamine 2 receptor antagonist, while for the aripiprazole, it is the D2 partial agonist. The adverse effect of the most of this drug, it affects the heart and can result into prolonged QT interval, can result into extrapyramidal symptom. As I said, it is like came with dystonia, with tremor, Parkinsonian tremor, and have also anticholinergic side effect. For the clozapine, it can cause agranulocytosis, so we need to monitor the patient weekly for total WBC. And there is a risk also for seizure with this drug, but it is dose related. For olanzapine, there is the risk of weight gain, and for the risperidone, increasing the prolactin level. This table is we can recognize in this table as a side effect, the common side effect of each drug. Like in the first drug, the aripiprazole, the most common side effect, it is extrapyramidal disorder or extrapyramidal symptoms. And for the clozapine, the most common side effect, it is drowsiness and the weight gain. And for haloperidol, the most common side effect, it is extrapyramidal symptom. Just to know the most common side effect for each one. Next. This is also continuation for the others drug. We can take the olanzapine. As I said before, the most common side effect, it is weight gain. Next. Tardive dyskinesia. When we call tardive dyskinesia, that means when the patient he have repetitive involuntary movement in the mouth and in the limb muscle, and it is the most common affect the older age. And when the antipsychotic started, as soon as the symptom improve, we should also educate the patient about what is the tardive dyskinesia and about the possibility of the symptom to continue and to be irreversible. In 2017, the FDA approved that the valbenazine, it is the first medication that used for treatment of tardive dyskinesia. Next. Let's talk about the delirium. We call delirium when the patient he have wax and waning in the level of the consciousness. If the patient came with wax and waning in the level of the consciousness, we tell he have a delirium. Also, he have a hallucination. One of the symptom hallucination, especially the visual hallucination, the misperception and alteration or disturbance in the sleep cycle and cognitive dysfunction. And the onset of the delirium, most commonly it is acute onset and can be secondary to underlying cause like metabolic disorder, infection, substance abuse or substance withdrawal, urinary or fecal retention. So we need to examine the mental status of the patient and to know if he have multiple cognitive impairment. And also we can do the ECG. We can find he have diffuse slow EEG. The EEG, sorry. For treatment of those patients, we need just to address the underlying cause, and we can give them haloperidol as needed. For the delusion disorder, in the delusion, as I said before, the patient he have a fixed false belief. When we have this fixed false belief for long standing without any hallucination, and the patient he have normal mood and no cognitive impairment, we say he have a delusion. So if he have false belief more than one for more than 1 month in the absence of other psychotic symptom, he have delusion. And it is most common or most frequent among the women, and but most severe among the men. In comparison to schizophrenia, the patient typically they have higher functioning with delusion. They will be more functioning with lack of psychotic symptom. For the management of the patient with delusion, we need to reassure the patient and to improve the sensory deficit, and sometimes we need antipsychotic medication. Other psychotic symptom in mood disorder, if we found delusion in the patient with depression, we say this patient he have extreme self hopelessness, and that reflect extreme self hopelessness or confection of ill health. And if we found this delusion in the patient with a mania, we say this patient he is grandiose. We will talk about the dementia. If we found patient in the dementia, the patient experience both hallucination and delusion, and it is less complex than the delusion which is seen in the schizophrenia or mood disorder. And the patient with dementia, he believes that one of his belong has been stolen, or one of his belong has been persecuted, or one of his boss is unfaithful. So if we found elder patient he have dementia, we should exclude the underlying condition. We should exclude if he have depression, and exclude the hypothyroidism, because also it can result into can be presented with dementia, which is called pseudodementia. So we need to screen those patients for the depression, and for TSH level, and for B12 level. Next. In dementia, we can the slide before. Okay. In dementia, we can use antipsychotic treatment, but we need careful consideration for the risk and the side effect of the treatment. We can start with the non-pharmacological intervention, like redirection of the patient, reassurance. If the patient start to have physical aggressiveness or severe distress or psychotic symptom, we can start a trial of low dose of antipsychotic treatment. All the antipsychotic agent, it is carry FDA warning regarding increasing all cause mortality in the patient with dementia. The psychotic symptom in the patient, when psychotic symptom because of another medical condition, we can find delusion and hallucination without any cognitive impairment, and that can be the result of the patient with a medical condition like Parkinson's disease, or like a stroke. And also the delusion and hallucination may be not because of the disease, because of the side effect of the anti-Parkinson agent. And some patient, but some experience visual hallucination before start the medication itself. We need, if the patient he have anti-Parkinson treatment we can reducing the dose, or if taken non-essential, we can just stop it to provide or to relieve this psychotic symptom. First generation antipsychotic may worsen the Parkinsonian symptom. And we need to use this antipsychotic treatment cautiously if the patient he experience significant emotional distress, and also if the symptom lead to dangerous or upsetting behavior, and consider the bima vanicine for the treatment of the psychosis in the patient with Parkinson's disease. The psychotic disorder due to we continue here in the medical condition. The prominent physical hallucination, if we found patient with prominent physical hallucination, can be it is a diagnostic feature for the dementia with Lewy body. So those patients with dementia with Lewy body, they are highly sensitive to the antipsychotic medication because it can worsening of extrapyramidal symptom, and there is no trial data available for to guide the drug choice. There are case report of significant improvement with cholinesterase inhibitor, and non-pharmacological treatment like redirection and reassurance of the patient also can be effective. The substance abuse or psychotic disorder because of substance abuse, there is some drug abuse can cause psychotic symptoms like alcohol, cannabis, cocaine, either intoxication with this drug or withdrawal of this drug. And many classes also of the medication can result into hallucination and delusion, like the blockers, interferon, cyclosporine, steroid, antiarrhythmic, antineoplastic drug, antiviral drug. All of this can have hallucination or delusion. The isolated hallucination in Charles-Bonnet syndrome. In this syndrome, the criteria we have patient, he have visual hallucination, silent visual hallucination, visual loss, and he have insight. That insight, he is a patient, he is aware, or that the perception he see it is a visual hallucination. It is not real, but still he report that it appear absolutely like real or as a vivid. And there is also lack of the evidence of the brain disease and psychiatric disorder. That means if we found patient with visual hallucination or visual loss, and this hallucination, he know in himself it is not real, but still he have report it is like real. This which we call Charles-Bonnet syndrome. Next. For the management of this syndrome, the best treatment information, to give the patient information and support, and to reassure the patient this hallucination, it is a sign of eye disease, it is not for mental illness. And few patients have partial insight or less insight and became very distressed by this symptom. When this symptom is distressful or can lead to dangerous behavior, caution trial of low dose atypical antipsychotic treatment can be beneficial. We reach the summary. Psychotic symptoms are defined are either hallucination or delusion, and psychosis occurring for the first time in the late life, in the age more than 40, often due to neurological condition like the stroke and dementia. 10 to 15% of the cases with schizophrenia first come late onset in age of 45. Only after other medical and mood disorder are excluded, we can diagnose schizophrenia like psychosis. The antipsychotic are effective in late onset schizophrenia and in early onset schizophrenia. And when the psychotic symptom it is arising in the patient with depression or mania, the symptom it is mood congruent. The dementia with Lewy body it is associated with characteristically visual hallucination, and the antipsychotic should be used quite cautiously in the patient with the dementia or Parkinson's disease. Thank you. If any question, I'm ready.
Thank you so much, Dr. Shiraz, for this very informative presentation. And if there is any question or comment before we move to the third topic of the day. Okay, so if there is no questions, our third topic of the day going to be presented by Dr. Eiman Ahmed, and it's about write spectacular and concise thesis statements. Dr. Eiman, if you're ready, you can start.
Thank you so much, Dr. Sam. Assalamu alaikum, everyone, and good afternoon. I'm going to be presenting the thesis and how we use summarize for that. So if you would allow me, I would like to share my screen over here. All right, can you see my screen?
Yes, we can, Dr. Eiman.
Perfect. All right, as I mentioned, my name is Eiman, and I'm going to be talking about the using of summarize tool to craft concise and powerful thesis statements in the medical research. So why is thesis statements matter? A thesis is the main argument or the central message of your essay or research paper. So it's very important to provide clarity and direction on that statement, and also to anchors every paragraph. And you need also to tell the readers what to be expected. So the challenges that we face in medical thesis writing is usually there's a dense and complex information. So the writers will struggle with long, widening summaries and vague or unconfused claims, or I'm sorry, unfocused claims, and overwhelming background information. So the problem here is hard to condense complex topic into 1 to 2 clear, strong sentences. And here comes in the help of the summarizer tools. And it's basically an AI-based tool that condenses large blocks of text into concise summaries. So it's helpful in a sense of it helps identify the core message in literature. It also refines your focus for thesis formulation. Those AI examples could be something like ChatGPT, Quillbot, Wall2, and also Smarty. So how does summarize help with thesis writing? So the key use cases is summarize long research articles, which extract main findings and combine multiple article summaries, so spot trends or gaps, and refine your research aim into one clear statement. So they help bridge the gap between idea, overload, and precision. So the thesis formula of summarizer plus presenter. So I'm just going to give example of what do I mean by summarizer and presenter. So summarizer is a chronic kidney disease disproportionately affects minority population. So the presenter is this study aimed to evaluate whether current screening protocols address this disparity. So the thesis is going to be a chronic kidney disease disparities affect minority population, and the study evaluate whether current screening guidelines address these health inequalities. So let's demonstrate before and after summarizer use. So the original text from an article abstract will say something about hypertension is prevalent among Black adults and is associated with a higher rates of end-stage renal disease. Various studies have identified both genetic and social determinants. The summarizer output will look like Black adult experience higher hypertension-related ESRD due to complex factors. You can see here the difference. It's very summarized, it's clear, and it's directly to the point. So the thesis based on summary, this research explores how social determinants contribute to higher ESRD rates among Black adults with hypertension. That's more concise, as you can see. So integrating summaries into your workflow. So when writing your thesis, summarize key articles, understand the landscape, and use those summaries to write a focused research question. And then third, you draft a thesis statement that reflect the problem, the gap, and your contribution for sure. And this is my reference, and thank you so much. If anyone have any question, I'm ready to answer.
Thank you so much, Dr. Eiman, for the presentation. If no one has any question, our last topic of the day going to be presented by Dr. Nadine. and it's the ultimate guide to expert interpersonal skills. What are soft skills? So Dr. Nadine, if you're ready, you can start.
Yes, sure. I'm going to be sharing my screen right now. Just a second. So is my screen clear for everyone?
Yes, it is. Thank you.
All right. So hello, everyone. I hope everyone is doing great. So first, I'd like to say that I've presented a lot of topics during my fellowship, whether it was about research, about geriatrics. But today's topic was very special. I had a great time actually preparing for this presentation. It was very informative for me. It was about a very important skills that everyone would need, not only in medicine, but I believe everyone in different fields. In today's day and age, it's very important to master and expert the interpersonal skills. So today I'm going to walk you through a guide to expert those skills and talk more about those interpersonal skills. So first, I'm going to talk about what are interpersonal skills. So interpersonal skills are the abilities that we use to interact and communicate effectively with other people. They help us to build relationships, work in teams, and resolve conflicts and understand others. I'm sure all of us have at some point created a CV, and in the CV you have to write some of your soft skills. Those are the skills that I'm going to be talking about today. It's either called soft skills, people's skills, or interpersonal skills. There are things like communication, empathy, active listening, emotional intelligence, conflict resolution, and adaptability. So starting with communication, there are two types of communication that I'm going to be focusing on today. First being verbal, and the second is non-verbal. So the verbal communication, the aim of the communication has to be that you have to be, there is clarity and simplicity in speaking. You need to focus on adjusting the tone to the situation, using open-ended questions, and avoiding filler words. So by filler words, I mean there are words or sounds that we use to fill pause while talking. It's like using basically, oh, I mean, right, okay. It's okay to sometimes use them, but you need to be aware that they actually weaken your message. Why you should avoid them, those filler words. They make you sound unsure and unprepared. It distracts the listener from your main point and reduces the clarity and confidence. So how can you reduce the use of filler words? It could be as simple as pausing silently before answering and before talking. Think before you speak and practice slow, intentional speech. Other way you can do that is by recording yourself and identifying the patterns. Coming to nonverbal communication, it is as simple as body language, posture, eye contact, facial expression, tone of voice, personal space awareness. So to master these nonverbal communication, you need to match your words with your body language. So why it matters actually, the nonverbal communication? According to Albert's communication model, it says 55% of communication is actually body language, and 38% of it is the tone of voice. So, and only 7% it's the actual words. So more than half of your communication is nonverbal. That's why you have to practice and master that to have effective communication. Example for poor nonverbal signs, it could be avoiding eye contact. It makes you seem dishonest and unsure. Crossing arm, you can appear defensive and closed off. Looking distracted makes you show lack of interest. Slouched posture, it signals low confidence. So what are an example of a strong nonverbal communication? A strong nonverbal communication could look like a good eye contact, but make sure you're not staring. Open posture, arms can be relaxed and facing the speaker, nodding or using facial expression to show engagement, appropriate gestures while speaking, and remember to be calm and have a confident tone. Another important interpersonal skill is active listening. So I came across a quote from a book that is called The 7 Habits of a Highly Effective People. It says, most people do not listen with the intent to understand. They listen with the intent to reply. And this is something you want to avoid. So active listening is a very important skill to master. Active listening simply means fully focusing on the speaker, understanding their message, and responding thoughtfully, rather than just waiting for your turn to talk. So a key elements for active listening. First, you have to pay full attention. No distraction, turn off your phone, avoid multitasking, just focus on one thing and listen carefully. Second thing, body language. Make sure that you're facing the speaker, maintaining a good eye contact, and nodding to show engagement. Number 3, no interruptions. Let them finish their thoughts before responding. Number 4, clarification. Ask open-ended questions. You can use questions like, can you tell me more about that? It shows engagement and you're asking for clarification at the same time. Number 5, reflection. Paraphrase to show understanding. This is something like the teach-back method that you use with your patient to make sure they understand what you're saying. So you also can use that to emphasize on active listening. So you can ask, and so you can say something like, so what you're saying is, and then you can paraphrase whatever they said. Number 6 is validation. Acknowledge the feelings. This shows empathy. You can use something like, that sounds really difficult. I'm sorry that you're going through that. And according to Harvard Business Review study, leaders rated as the best listeners are the ones who make the speaker feel safe, ask thoughtful questions, and guide conversations without dominating. Now moving to emotional intelligence, or EQ. In a very real sense, we have two minds, one that thinks and one that feels. This is a quote from the author of Emotional Intelligence. Emotional intelligence is basically the ability to recognize, understand, and manage your own emotions. At the same time, you need to recognize, understand, and influence the emotions of others. This is simply what emotional intelligence is. There are 5 core components for emotional intelligence using the Daniels-Goleman's model. Number 1, self-awareness. As Socrates says, know thyself. It means recognize your own emotion and understand how they affect your behavior. Number 2, self-regulation. You need to control your impulsive feelings and manage stress and adapt to change. There's a beautiful quote that says, between stimulus and response, there's a space. In that space is our power to choose our response. And this is how you can master your self-regulation. Number 3, motivation. Stay driven by internal values, not just rewards. Persist in the face of obstacles. It means you have to be a self-motivated person. Number 4, empathy. Understand other feelings and respond with compassion. Number 5, social skills. Build relationships, communicate clearly, and manage conflict with grace. But why does emotional intelligence matters? Well, according to Talent Smart research, 90% of top performers have a high EQ. And EQ is 4 times more important than IQ for long-term career success. Strong EQ equals better teamwork, decision-making, leadership, and patient care. In medicine and healthcare, it helps in breaking bad news, handling anxious patients, and navigating conflict. Enhance collaborations with colleagues, and reduce burnout by improving resilience. And a very important topic now is the conflict resolution. What is conflict resolution? It is basically the process of addressing disagreements in a healthy and constructive way, turning friction into understanding and not division. Because simply peace is not the absence of conflict, but the ability to handle conflict by peaceful means. So first you need to understand why does conflict happens. There could be as simple as miscommunication, differing values or goals, emotional stress or burnout, lack of empathy or listening, and power imbalances. That's a key part of resolving a conflict, is understanding why it happened at the first place. Now, the key skills for resolving the conflict is active listening. Let people feel heard without interruption. Reflect back what they said to show understanding. Show empathy and acknowledge the emotion without judgment. You can ask why might they be feeling that right now. Stay calm. Use a calm tone and open posture. Focus on interests and not position. Instead of I want this, ask why is this important to you? You need to find a common ground. Identify shared goals. For example, patient care, team success, and propose a win-to-win solution. And most importantly, apologizing when needed. It could be something as simple as, I'm sorry, I completely misunderstood the situation, and I'm going to work on improving that. So actually, apologizing could be the most powerful thing you can do to maintain professionalism and to maintain your relationship with your colleagues. Approaches that work to resolve conflicts. Number 1, the I statement method. You can simply state that I feel, and tell your emotion, when, in that situation, because. So I feel, when, because. This helps avoid blame and keep the focus on your experience and your side of the story. Number 2, the interest-based relational approach, which is widely used in healthcare teams and mediation. So the IRB approach is developed by Roger Fisher and William Ury, the authors of Getting to Yes, is a method to resolve conflict while protecting relationship. It basically focuses on interests and not positions, respecting people even with opinion differs, and collaboration to reach mutually beneficial outcomes. Number 1, and this is a couple of details about that approach, you need to separate the people from the problem. Don't let the issue cloud the real conflict. Focus on the issue and not the personalities. This is number 1. Number 2, respect all parties. Everyone's voice matters, and create a safe space for dialogue. Number 3, listen first and talk second. Understand their interest before stating yours. Ask open-ended and non-defensive questions. Number 4, focus on interests and not positions. So position is saying like something like, I want the night shift. Interest, I need time to care for my child. Number 5, work together for solutions. Brainstorm options that meet everyone's core needs. Collaborate instead of compromise. Number 6, use objective criteria. Base decisions on standards, not emotions or power. Example, guidelines, policies, shared goals. And lastly, giving and receiving feedback. There's a beautiful quote that I came across that says, feedback is the breakfast of champion. Not only receiving, but also giving a feedback. It helps you grow, build trust, and improve relationships when it's done kindly, clearly, and constructively. So giving feedback, while giving your feedback, you need to be specific. Don't say something vague like great job. Say, I liked how clearly you explained the risks to the patient. You need to be kind and respect the person. Focus on the behavior and not the identity. Be honest. Don't sugarcoat, because truth builds growth. While giving a feedback, you can use the sandwich method. You can start by saying something positive, state the things that you liked, or start by saying the things that worked. And then you can go ahead and talk about the constructive critique and focus on the areas of improvement. The areas that needs more work and they could need a lot of work to improve. And then you have to end it with something positive. End on a note of encouragement and confidence. So again, positive, constructive, and then positive. For example, your presentation had a great flow, but one suggestion, slow down during complex parts so others can follow. But overall, it was a very strong and clear. So this example shows the sandwich method. He started by saying your presentation had a great flow, which is a positive note he started on, and then the constructive critique, and then again ended it with another positive note of encouragement and confidence when he said it was very strong and clear. So receiving feedback, while receiving the feedback, you need to stay curious and not defensive. Listen fully before reacting and ask follow-ups. Can you tell me more about what I could improve? And what did you notice that made you say that? Always thank the person, even if it's hard, even if the feedback was hard to hear. Reflect later and decide what to take on. Remember that criticism is like rain, should be gentle enough to nourish a man's growth without destroying his roots. Which goes back to the point that your feedback has to be specific, kind, and honest. A little summary, interpersonal skills are connections, communication, and compassion. They can be learned, practiced, and improved over time. Strong relationship creates success in every field, and people don't care about how much you know until they know how much you care. This brings me to the end of my presentation. I hope it was beneficial for everyone. And I'm going to stop sharing right now. If anyone has any questions or any comments about the presentation.
Thank you so much, Dr. Nadine, for this very important and informative presentation. Yes, we all need to work on our interpersonal skills, and we learned a lot from you. Thank you so much.
Thank you.
So Dr. Nader, I guess we reach our last part, is the project update.
Yes.
I do have some updates in regards to the a great team project that we just started on, if you don't mind.
Yes, Dr.
Yes.
Eiman.
So we're trying to, we just started on this new project. So we're trying to see a comparison. It's a systematic meta-analysis research study. We would like to see the comparison between an AI prediction and a SOFAS in a septic patient admitted at the ICU with stroke. So we're still at the beginning steps of the study, and we're just, rolling the ball.
Excellent. That's good.
Thank you.
Thanks for sharing.
Absolutely.
And Dr. Nader, I also have an update about the mobile application you talked about last week. So you show us how to use the AI to help us develop a mobile app. So I followed your steps and created a mobile app. I can show you briefly the steps.
Yes, yes.
And okay, so the screen. So I started by giving ChatGPT like a command, like, okay, so first of all, I thought about a mobile app that can help older adults with memory issues, especially like trouble remembering where they park their car. I have this problem, me myself. Sometimes I forget where I park my car. So yeah, I told ChatGPT to develop an app, in case I forget where I park my car. So it gave me the full code, and then and it gave me the whole, like, what to do and the steps. I find it a little bit difficult, so I went and like saw some YouTube videos. Let me just share with you that. I'm sorry, yeah, some YouTube videos to give me more idea on how to do it. So I find this video and another one, and it walked me through the whole steps, like on how to create the app. So the code from ChatGPT, I put it in this code pin, yeah, like website, and I put the code in, in different sections, and this is the app. It name it for me, Find My Car. It have only 2 tabs: save the car location and find your car. And so it's gonna take you then to other websites, and also going to prompt you to go to Canvas to create your logo and how to crop the logo using Photopia. And at the end, it's gonna also prompt you to go to web into app, like in order to take your web app into a mobile app. And this is my final simple application. It's just to save your car location. And then when you're ready, you're gonna hit find my car. It's gonna use Google Map. And it can also work offline. It can work offline and, take you to where you park your car. Yeah, so now I have it on my phone too. So, and I tested, I gave it to my family and some friends, and it's working. It needs some improvement as you advise on your email.
Could you please tell me which email you're referring to? I need more.
That's great. Excellent. So basically, you did a great job, and this is how to use the AI to develop an app that's solving a problem. So sometimes, as you mentioned, we have some problems, but if you focus on a target group, let's say the elderly, and they have problems with finding the car in your case, then this app hopefully will help them. And as you mentioned, there are a lot of assistants there. So YouTube's and some of the websites that you use, they may have some communities where if you have a question, most likely someone has similar question in the past, so they answered that question, or at least they have some expertise and they can answer your question. But great, I think you did complete the app, and now it's just adding some features or some additions, and maybe involving some of the fellows who are interested in
Okay.
the exam. Thank you. Thank you so much.
Thank you for this learning opportunity. It's really great to learn how to develop and go through all the process. Thank you.
You're welcome. And if you don't mind, if anyone else would like to develop something similar, they have an idea and they go through the AI and they get the code, for example, they created the website where it's functioning online, but they want to make it as a mobile app that can be installed as like in your case in Samsung or Android phones. So you don't mind if you answer some of the questions if you are available?
Yes, sure. Anytime they can email me or text me, and I can go back and chat with them. Yeah, and also I'm gonna send my mobile application to in the group so everyone can use it and test it and give me suggestions.
Sounds good. So one of the suggestions, I think I sent you the email, but I'm opening it to the attendees here. If anyone is interested in helping with her project, maybe one thing you can join and work as a group to just work on the translation, for example. So she created that in English. Maybe some of you can work on translating it into Arabic. Some of you might speak another language, Hindi or Urdu or any other language specific to your population. So maybe you can help others. I know in the past we talked about Spanish language. We had one fellow, she was from South America, and she was speaking Spanish. So any language we can add, it will increase the group that can benefit from this app in the future. And you can put that in your CV that you work with a team in developing an app that helps older patients with whatever condition, let's say in this case, mild cognitive impairment or deficit or something like that. Thank you, Dr. Wissam, for sharing. Anyone is interested, maybe they can email you or put their name or email in the chat so that we can get in touch with her.
Yes, Dr.
Dr. Nader,
Yes, go ahead.
I also started to make an application using the AI. In my practice, I encounter a lot of patients with chronic kidney diseases, and I found that their main problem is too much medications and the problem with their diet. So I asked, I started to make the application. I didn't finish it yet, but I completed a lot of steps. Can I share my screen?
Yes, please. Yes, please. Go ahead. Thank you so much for sharing. So this specific group also is in need for something for education, for example, and patients with renal conditions. Go ahead, Dr. Ahmed, if you want to share the screen.
I will share my screen now. I'm trying to share it.
So I'm just, okay.
And I'm trying
just
to share screen.
Add one more comment for the fellows who are here. If from what we saw from both Dr. Wissam and Dr. Ahmed is that when you think about your patient population, you might find some problems or some difficulties or some issues. So we can think about solving these problems or issues by developing an app that might be useful for this group of patients that you take care of. And it shouldn't be a complex mobile app. It could be just a simple idea, and then you can build on top of that as you go along. So go ahead, Dr. Ahmed, when you're ready.
Can you see my screen?
Yes.
So I asked ChatGPT to create or to give me an idea of 5 mobile apps about to help patients with chronic kidney disease. He gave me 5 ideas. The first one was CKD daily tracker for self-monitoring and the early detection of complications. Its value is to monitor vital signs like blood pressure, weight changes, urine output, edema check, medication reminders, which is so important for patients with kidney disease. Alerts for dangerous trends like sudden weight change or uncontrolled blood pressure, to be synced with Bluetooth blood pressure monitors and smart scales, and being the app being able to auto-generate PDF reports for the physician. The second idea was renal-friendly diet coach, which is centralized about the personalized dietary guidance for these changes. And he gave me also other ideas like one for dialysis, one for staging of CKD, and the other for the last one for drug-related side effects. I asked him to combine the first and second app. The first, which is daily tracker of vital signs, and the second is the diet one. The ChatGPT started to combine CKD self-monitoring app 1 and renal-friendly diet support app 2 into one app, which is called Renal Care Plus. Then it started to demonstrate the details, daily health tracker, including all vital data, kidney safe diet coach about all details of the dietary guidance to protect kidney function and reduce complications. And he also allowed additional features like language, region customization, local foods units, education hub, emergency system, and the caregiver access. Then I asked him to start make a title for the application and start to create the application. The title he has chosen was Renal Care Plus, a smart companion for kidney health. And this was the problem is chronic kidney disease, and the solution is this app. That's integrated mobile solution to empower CKD patients to help them to follow up their daily vital signs, receive personalized stage-specific dietary guidance, help them to connect with the doctor through the PDFs that can be extracted from the app. And all these features will be included in them, including daily health monitoring, nutrient food tracker, barcode scanner for packaged foods, personalized meal plans, recipes, medications, appointment reminders, auto-generated PDF reports for physicians, multilingual, culturally adapted options, family caregiver portal. After that, when I asked the ChatGPT to create the code, he created first the wireframes and give me some pictures suggested for the app, like this I am showing now. Then I asked it to if he can create the app. He responds that he can't code and deploy a full mobile app on your device or the App Store directly, but I can absolutely help you build it step by step using the right tools. And he suggested 4 tools and recommended the first one, which is Flutterflow, low-code, Firebase backend. He told me that I recommend Flutterflow if you are aiming for a polished medical create app. So I asked him to make me the code and the file essential for this app, and he asked me some question about the background, the colors, and asked if I want to another language, and I asked him to incorporate Arabic also. And finally, he makes the code and send me the link today, which is the link. I will show the link now. This is a link. Here is your download link for the complete Renal Care Plus Flutterflow. And what I recommended to do is to download this zip file and upload it on the Flutterflow website to start creating the app and making it a full functional application. I can't do it now as I am entering from my mobile. But when I reach my laptop, I can create it and show it to the group the next meeting, inshallah.
Inshallah. That's great, excellent, wonderful work. So again, it depends on how you approach the AI in this situation. So Dr. Ahmed basically asked ChatGPT for some ideas to help his patients. So you don't have to come up with an idea even for a problem. You just mention that you have this group of patients and ask for suggestions of how to help them. So there are common problems and there are specific problems, and AI can help you identify different problems. So from the 5 suggestions, Dr. Ahmed mentioned that he combined 2. So if we go back and ask ChatGPT for the other 3 suggestions, maybe you can put them for the group, and some of the fellows might be interested in one of them, or maybe some might be interested in all 3 ideas. So maybe we can develop more apps from the prompt that you started with and the 5 suggestions that they gave you. So I think if any one of you is interested in internal medicine, in family medicine, in nephrology down the road, these might be good options to start working on. And Dr. Hamid showed us how to do that using AI. Sometimes you can use the same way Dr. Wissam used, like just the HTML code, and it will create you a web page, and then you can modify that to make the app certain steps that can be done. So you can use the web based app, mobile app, like Canva. It has AI tool in it. And if you give let's say, Dr. Ahmed, can you share the first section where it suggested the 5 app ideas?
Okay, doctor, I will share now.
Number 3, what was it, for example?
It's about dialysis. I will share it now.
Mhm.
This is my dialysis buddy. Empower dialysis patients with self-care and the planning tools, including
for
dialysis
example,
schedule.
yeah. So if you copy paste all this from the title, my dialysis buddy, all the way to bonus patient forum or peer support chat, copy all this and then paste it in Canva in the code section. And Canva will create a web-based simple format of the mobile application. So like a screenshot of what the user can click on or can add or whatever. And then we can modify that as we get along. So this is one idea for some of you. If you are interested, you can contact Dr. Ahmed for idea number 3, for example. Some might be interested in idea number 4, for example, if you scroll up or down, yeah. So CKD Navigator, for example, or number 5, Kidney Met Safer Safety Checker. So this can easily be helping you create 2 or 3 more mobile applications. So we have the ideas now. We have the prompt. If you just copy paste one of these into the ChatGPT or into Canva, it will create the code for you and it will show you how it will show up. And if you need to modify it, you can just ask the AI again to do whatever similar to just Dr. Ahmed mentioned. So every step you add more to the prompt. So you just ask if you want to change the color, if you want to add another language, if you want to do this and that. So it's going to be easier down the road. So if you have questions, again, you can ask Dr. Ahmed and Dr. Wissam as well. Thank you so much, both of you. And this is great. And I hope we can move on and get this product at least to the public. We can work on in the future to build this app so that can be uploaded to the Google Play Store. We did that in the past. We were successful in building apps and uploading it, like 5 of the apps in Google Store, and 1 app was uploaded to Apple Store. So we have experience in doing that. So down the road, maybe we can think about that as well. Thank you so much, everyone. Any other?
Dr. Nadine, can I say something?
Yes, please, Dr. Nadine. Go ahead. And
Yeah,
Rahmat, all that.
I just wanted to check if you can check your email for the curriculum about the learning series that I've started earlier.
Yes,
if you
I
could
have
approve
to look at that. Yeah, I looked at your email and I'm going to just review that and give you a feedback. Most likely we will go with some steps, and I'd like to add one suggestion is to involve some of the fellows who are interested in similar topics or fields. Like if someone is interested in internal medicine, they can join you. If they are interested in neurology, can help with presenting or developing the curriculum, something like that. So, but in general, the structure, I think it's a very good idea. Yeah.
Perfect. I was thinking about that. Like each week we'd choose an area of interest, like 1 week about neurology, other week about nephrology, and we could create a WhatsApp group with all the fellows that are interested in presenting and creating the presentation together. Like it would be a teamwork thing.
Yes, that's what I meant when I mentioned the suggestion to add more fellows. So it's gonna help them and it's gonna help you. It's gonna help the program when they are working in teams.
I would love to, yeah, of course.
But yes, in general, go ahead with your next topic, for example, for next week, and build on that. So go ahead. Thank you.
Hello, Dr. Nadir and everyone.
Hello.
This is Sana Mohamad Ali. Thank you for this opportunity. And I also developed an application, and the name of the application is Chronic Pain Tracker. And I want to thank Dr. Wissam and Dr. Abir to help me to navigate through the process. And also, I want to mention that when you try to send the email to Dr. Nader, make sure to reply for his email at telegeriatric, because when I try to send the application link through the other email, it doesn't respond because it's blocked. That's it.
Thank you so much, and good luck with your app, and the fellows here will help you. Thank you.
Thank you.
Hello, everyone. Hello, Dr. Nader.
Go ahead, Dr. Noura.
So I've been working on an idea for an app related to the field of oncology with the use of ChatGPT. So it's called OncoGuide Cancer Care Companion, designed for older adults undergoing cancer treatment as well as their caregivers. So the app, its goals include supporting treatment adherence and educating them about the potential side effects of the medications, and improving early detection of complications such as neutropenic fever, dehydrations, and reducing the risk of ER visit and exposing them to infection, enhancing the patient and the caregiver confidence, and supporting continuity of care for complex oncology regimens. So I use these objectives with the assist of Canva to help me design the app. It consists of many categories. The main screen shows the patient's today's plan, the treatment roadmap, and the quick symptom tracker. And then each category is further subdivided in details to cover all the app objectives. I created the code, and I had a bit of a difficulty in finishing the app. So I think I'm going to use Dr. Wissam's help to guide me further and to finishing the app. I contacted many of the fellows in the group that was assigned to, and 2 of them responded back. So I think we're going to work together, and we're going to ask also Dr. Wissam's help to finalize the application.
Okay, sure, Dr. Noura, we can work together. And also thank you, Dr. Sana, and we can also work together, inshallah.
Okay, thank you.
Thank you so much, all. Dr. Ahmed would like to add some comments.
Thank you, Dr. Nader. I was willing to ask one question about if I am able to make a presentation or certain or a topic on nutrition, like the healthy nutrition, the popular diets. If it's possible to schedule this topic in the coming days, I am ready to make a presentation.
Do you mind if you look at the agenda? I think there is a topic about nutrition. I'm not sure if it's done in the past few weeks or it's gonna be in the coming few weeks. Let me help you identify that. Just a second. So if you go to the app, so you scroll down to the upcoming Zoom meeting. You can search for specific. So in January, we will talk about that. But we can move it up if that's far away for you guys. So let me know when you are available to work on that. So the data or the file. Usually we use PowerPoint presentations that were made for geriatric fellows, but you can modify that and you can present it. We focus on geriatric population. This is why you can modify it and edit it to meet your needs. Thank you.
Okay. Thank you, Doctor, so much. Thank you.
Hello, Dr. Nadir. My name is Eiman Ahmed.
Yes,
I wanna tell you about my project. Actually, I did the same like Dr. Ahmed Khalifa, kidney disease tracker. And I want to appreciate also Wissam and Sana. And Wissam yesterday, she did difficult with me to complete my project through her videos. And finally, we complete that. And I want to share it for, if you don't
yes,
mind. Yes.
sure, yes.
Actually, I follow the same step like Dr. Ahmed about ideal with kidney disease patient, and actually I want to share my screen. Don't know what happened. Are you see my screen, guys?
Yes.
Okay. You see my screen. Actually, I want to show you. This is the kidney tracker. This is the app. Looks like this.
Dr. Habir, we can't see. We just
Oh,
see.
we can't see?
Yeah, I just see a whiteboard.
Oh. Okay, whiteboard.
So while Abir is coming back with her presentation or demo, I just want to share with you that a few weeks ago, we talked about how to use AI to develop an app, and you have to go step by step. The first step is to ask ChatGPT, for example, or any other AI tool to give you an idea about a mobile app that can be useful for your patient population. For example, you are interested in pediatric, in neurology, in pediatric, for example, then your prompt might be specific to that group. Or in these cases, for example, both Ahmed and Abir were interested in nephrology, so they mentioned about patients with kidney disease. So the AI will give you an idea about what major problems. Let's limit it to 5 problems or ideas, and you can pick one of them and then use that to elaborate. So you can say, can you elaborate on number 1, for example? It will show you the steps of how to develop the app and why it's important. Then you take that prompt and tell the AI to build the app as a user-friendly. The same way can be done in Canva. You you can take the prompt and paste it in Canva, and it will create the web-based app for you. So when you are done, then you can test it and see if there is any improvement that you want to do. And then next step is to share it with some other fellows, families, friends, and see what if they have any feedback, and then we can move on. So it just takes one step at a time. Try it, see. It's not going to be difficult. There are a lot of videos to show you how to solve any issues that you may face, as Dr. Wissam mentioned, and solved most of the issues that she faced. Dr. Abir, are you back?
Yes, I'm here. Sorry. I want to reassure for your what you said, that when we follow the videos step by step, it will be very easy. And we're just doing this in 20 minutes yesterday.
Dr. Abir, I can share, I still have the file, and you can just, I
Okay.
can share the file and you can talk with, and explain.
Okay. Yeah.
So
Actually, I did it with Sam yesterday.
Yeah,
And we follow the videos step by step. And I think that's exactly what Dr. Nader said. Yeah, after we're doing the file and put it in a zip folder, after that you can upload in the tiny.host. And finally, we can deal with the canvas. I think when you follow the videos step by step, it's so easy. And finally, this is the app. We can put it. We ask you about the blood pressure and the weight, and what is the complaint today, what is the symptom. When you enter this three check, we can give you the advice. What can you do? How to decrease your blood pressure, decrease the salt intake, and what we do. And I think it is the easy one. And when you follow the videos that what Wissam shared, I think it is so easy and better. Thank you for letting me showing that.
Yeah, thank you so much, Dr. Abir. And also showed you that it's not that difficult. It's just need someone to try, basically. So you want to do something, just give it a try, and there are a lot of people who can help. Thank you.
You're welcome.
Any other updates or any other ideas or suggestions or thoughts that you want to share with us?
Yeah, Dr. Nader, how are you? I want first to thank all of you for today. It was amazing, and thank you for giving this opportunity to us. I just want to tell you that we sent our paper, melatonin and related to sleep problem in Alzheimer patient, in your email. It's done by Dr. Dalia, our team leader, and we are waiting for your positive feedback to pursue with publication.
Give me a second. When did you send the email?
I think it is now almost a month.
Oh, the name who sent it?
Dalia.
Okay. Melatonin, right?
Yes.
Yeah. So effect on sleep disturbance. So I will look into that and give you feedback soon.
Okay, thank you very much.
Thank you so much for the reminder, Dr. Ryan. Anyone else?
Dr. Nader.
Yes.
Sorry
Before
for interruption.
Give me a second. Just I want to share with you. In the past few weeks and maybe couple of weeks. I might be busy, so if for any reason you send me any request or question or review, if I don't get back to you, as Dr. Ran did now, just give me a reminder, send me an email, message, or some during the week meeting, just for me to go back in line, and hopefully we'll be working as a team in a good time manner. Go ahead, Dr. Ahmed.
Sorry, doctor, for interruption. Last couple of years, I have published 2 papers with my colleagues in the geriatric department in Ain Shams University in Egypt. One, I was the rheumatologist in the paper, and they were the geriatrics. One of the papers was comparing the disease onset of rheumatoid in younger patients versus elderly patients, which I think is a good one. And the second was to study the prevalence of cognitive frailty in elderly patients with rheumatoid arthritis. So I can, if it's possible, I can share these papers in the upcoming meeting. So.
Oh, sure. Sounds good. This is a great idea. So what we did in the past, like the first batch or a couple of cohort, we used some tools to review some of the articles, and then we assessed and analyze these articles and see how the authors come with the idea, so that we understand the concept of research question and the method that they used. So, and then the analysis method and the data they collected and so on. So maybe we can do the same with couple of your articles that you published, Dr. Ahmed. So it's going to be useful to know how they did it and build on that, so that we can do something the same way. Thank you.
Thank you, doctor. Thank you so much.
Excellent. Any other comments? Any other questions? New ideas? So last part I want to share with you is I'm going to share a screen for this. So if you are interested in, let's say, applying this round for ERAS, you may need a letter of recommendation. So I'll be happy to write some for you guys. So what I want from you is to use the app, so that I can write a personalized letter for each one of you. And to do that, you can go to the app and then go to request, and there are some comments or guidelines or points that you need to follow. So when you request, mostly you will request it from ERAS. So I want you to know that if you are applying for multiple specialties, let's say internal medicine and family medicine, or internal medicine and pediatric or something else, I want you to request a separate letter for each one, so that it will be specific to that specialty. And this might be easier for you when you apply. You just drag or connect each specialty with the letter that's corresponding. This information you may need, the name and the program and so on. And give me some time. It will take a couple of days for me to go over your information and the letter, and then upload it to the system in ERAS. So if you are interested in specific area, just make sure you update your task, whatever you did. So today you presented a topic, or you are working on a mobile application like Dr. Ahmed. What type of application? Let's say renal application for patients with renal failure, something like that. So when I'm writing my letter, I will mention that briefly, or highlight some of the achievement that you did. And this will help make the letter useful for you guys when you discuss. If you get an interview, it will highlight your uniqueness compared to the other fellows, and it will also give them an opportunity to ask you specifically about our program or about your input, your activities and research projects that you were involved, or presentation or educational material, something like that. So it's going to be useful for you. The more you add specifically in your request, the better the letter for you, if that makes sense. Any questions?
When I checked the app, the city, it was mentioned East Lansing. So is it changed now?
Yeah, so the program when we started, it was with MSU, Michigan State, and it was in East Lansing. Both of them, Oklahoma and East Lansing, are part of Lansing city. It's a metropolitan. It's like part of the city is called East Lansing, part of the city is Okemos. So in case they need to send actual letter, mailing it, the actual physical address now is in Okemos. So it's not going to be a big of a deal. If you submitted your letter last year, it's going to be in East Lansing. The new letter will be in Okemos. Both of them are part of Lansing area. Thank you.
Thank you for clarifying. Thank you so much.
You're welcome.
Much appreciated, Doctor. Thank you so much.
Anytime.
Hello, Dr.
I
Nader.
want also, Dr.
Yes, please go ahead.
And then
Go
Sabri.
ahead. I already spoke. Go ahead, Dr. Sabri, please.
Thank you, Dr. San. This is very kind of you. Hello all. Hello, Dr. Nader. Thank you very much for giving us this great opportunity. Dr. Nader, I wanted to ask you something, but I think that it's already asked here in the previous meetings, but I wasn't able to attend. I'm planning to applying next year, and I don't know. I didn't take my step 2 CK yet, so I'm a little bit confused because of the banned list that is recently published, and Sudan is one of them. So, what do you think is going to happen, or it is in like al-Maghrib? I don't know. Or should we wait for another release of from the White House? Or
Yeah, so I assume it's gonna be resolved, and I want everyone to work hard on getting your steps or documents finished and ready. It may not be soon, maybe it will take some time, but the need for international medical graduates in the US is high, and there are a lot of movements from different organizations, different hospitals to address this with the government. So I don't know how long it will take, but eventually it will be solved or resolved. And for you, if you, let's say, you are in Egypt, in Saudi Arabia, or somewhere where you want to take the steps, to advise, go ahead. Even if you decide to go a different route, let's say you want to go to UK, the studying itself, it will help you if you want to take some other exams like the exam in the UK or like Ireland or somewhere in the Gulf, they have their own board. So eventually the material that you are reading, studying, it will help you prepare for the other test as well. If you pass the USMLE step 1, 2, and 3, this will put you at a higher rank, and hopefully it will help you whenever or wherever you want to go. If you want to stay in the Gulf or to come to Ireland or UK, for example. The last part is that the demand here will put some pressure as we notice some of the programs, they are in need for some residents to get the residency programs going on. So I expect it will be solved, but I hope that will be sooner. Unfortunately, I cannot guarantee anything, but this is my
Yes.
advice.
Yes.
Thank you.
Thank you very much. That's very clear.
Go ahead, the person I think you wanted to ask or add comments.
Hello, I just want to thank you a lot for this opportunity because it wasn't easy to me to find a letter of recommendation, especially if it is personalized. So we really appreciate this opportunity.
You're welcome anytime. And I'd like just to advise you when you will be required to get some clinical experience. And if you have the opportunity to work with some of the physicians, from the start, from day one, I want you to request that I want a letter of recommendation and I would like to be like ready for that letter. So by the mid of the, say it's 2 weeks or 4 weeks, by the mid of that duration, ask them if there is anything that you can improve on. So let's say they want you to see more patients, so that the time where they will mention, oh, we want you to work hard on seeing patients or doing this or doing that or come early or whatever area that they may notice that you didn't do well. So when they write the letter at the end, they will say you were responsive, you were receptive to the feedback, you improved a lot, and so on. So it's gonna be a good, also personalized letter for you. If you set the expectation from the letter writer from the start, or at least in the beginning. Thank you.
Thank you for this advice. I will take it. And also, Dr. Nader, I have a question regarding the clinical experience. Is there a specific way to go through GME, graduate medical? Yeah, I forgot the E, what is for. But somebody told me that if I apply through GME, I can get free clinical experience in my Washington state, in my state. So do you know anything about this?
Okay, just give me a second. Sorry about that, Dr. Regarding the clinical experience and the GME, I'm not quite sure if there are some opportunities, but GME is like graduate medical education, and some of the basically residency program or fellowship programs are considered among the GME, graduate medical education. So anything after you graduate from your medical school, basically. So if there's a website that advise you to contact this program or that, go ahead.
Okay, thank you so much.
You're welcome. If there's no more questions or comments or suggestion ideas, I'd like to thank you so much, Dr. Wissam, and I'd like to thank all the presenters from today's presentation. You did a great job. Thank you for all the hard work and good presentations. Thank you all attendees from today's meeting and those who will come in the future. I wish you all the best. And if you have any questions, please contact me via email or send me a text or WhatsApp. Have a wonderful day or night. Assalamu alaikum.
عليكم السلام. Thank you, Dr.
عليكم
Dr.
السلام ورحمة الله وبركاته.
وعليكم
Thank you,
السلام.
Dr. Nader, and the presenters. Thank you very much. Have a great one.
Thank you very much, Dr. Nader.
Thank you.
Thank you, Dr. Nader.
Thank you, Dr. Nadir.
Thank you.